Thank you, Dr. Locke, Marcelo. I can't tell you what a pleasure it is to be here. I'd first like to congratulate and thank Fernando for inviting me. We've been friends for more than 20 years and have done a lot together. And also to really thank Marcelo, who was one of my professors when I was training at the University of Miami. And it's so nice to see so many of my colleagues who were all fellows together from all the different Latin American countries here. So again, thank you. My task is to talk a little bit today about hepatitis B reactivation. And I think it's becoming a very, very important discussion that we're having with our patients, but also with physicians who care for patients, whether they have an oncologic problem, whether they have a rheumatologic problem, and in particular amongst our fellow gastroenterologists all in the room. So to sort of set the stage, how do we define hepatitis B reactivation? And we can use different wording, but perhaps the easiest thing to do, it's truly the loss of hepatitis B immune control in a patient that has inactive or resolved hepatitis B infection. And I think the resolved portion is also important as we talk in a bit. It's characterized by the reappearance or an increase in viral replication occurring during or following immune reconstitution. And we typically see significant rises, which I'll go over, in HBV DNA followed by transaminase elevations. So I think we need to all understand the quote definition. And it's important because as I said earlier, as we are seeing more and more patients getting immunosuppression, TNF, medications, anti-TNF, the incidence of hepatitis B reactivation is on the rise, and it is preventable with education. And I think that's really the key point. If we were to educate the physicians to look for hepatitis B in the patient populations that they are going to place on immunosuppressive type agents, we can prevent hepatitis B reactivation from occurring. So education is critical. Not going to discuss much about that here, but again, I think that's our job to all go back to our communities to educate. The clinical range of hepatitis B reactivation is really across the gamut, and it can be from subclinical to severe hepatitis to liver failure and death. And if we think of the patient populations that may be affected, those are folks that in many cases have an underlying malignancy, so if they then develop fulminant failure from hepatitis B, they're not candidates for transplantation. And so again, the importance of looking for hepatitis B before starting patients on these therapies is important. Why? Well, we've heard a lot about the cccDNA from the previous two speakers. I'm simple. So in a pictorial fashion, someone had hepatitis B or has inactive hepatitis B, they have this cccDNA in the hepatocyte nucleus. And they're either under good control or they don't, or it's not being expressed, or if it's being expressed, it's going to be subclinical, right? We have an immune system which keeps it at bay if small amounts of virus are actually released, and there are studies in patients that have had hepatitis B and cleared where biopsies have been done, and you can stain the biopsy for HBV DNA and it can turn positive. So the virus still exists. If that immunosuppression, if that immune response is blunted from whatever, then it gives the virus an opportunity to proliferate, and we can then develop reactivation. And so you can see here a patient looked over time who had hepatitis B, now has undetectable virus with a normal ALT, under good immune control. Immunosuppression is initiated. First thing that you're going to see is an elevation in HBV DNA, and then with immune reconstitution, E antigen will become positive if negative, and the patient will develop elevated transaminases. And here's where the problem is. So the importance, again, is to try to find this beforehand. Dr. Locke had, I think, the seminal paper on this back in 1991, where she described 100 patients who with non-Hodgkin's lymphoma who were given chemotherapy. And you can see here, half of the patients develop some sort of hepatitis B reactivation, ranging from the subclinical to fatality. And unfortunately, it took another 20 years before the worldwide community recognized the importance of this work and recognized that this problem does exist. Here you can see just an example again from something done about 15 years ago, how immunosuppression and in addition of prednisolone to that and high-dose steroids can also increase the risk of developing hepatitis B reactivation. So we know the problem exists. It all comes back again to finding the patients beforehand and then being able to hopefully, initiate. We can divide hepatitis B reactivation patient groups into two. Those that are hepatitis B surface antigen positive with or without HBV DNA, and those who are hepatitis B surface antigen negative but have an isolated detectable hepatitis B core antibody. And since it's really quite common to see folks that have all markers negative other than a positive hepatitis B core antibody, that's a group that we need to actually look for. When does hepatitis B reactivation occur? Well, it can occur within 2 weeks of initiation of immunosuppression, but perhaps more frightful, it can occur a year out after stopping immunosuppression, which is why, again, it's so important to follow these patients. And that's a pretty distinct timeline. I think the last thing that we would want to do is treat someone, cure their cancer, or keep their Crohn's disease under good control, and then have them flare for hepatitis B that, again, could have been recognized and prevented. Risk factors for hepatitis B reactivation can be placed into 3 large categories: host factors, virologic factors, and then the type and degree of immunosuppression that is being given. What are some host factors that increase the risk of hepatitis B reactivation? It's more common in men. It's more common in people who are immunologically older. It's more common in those that have underlying cirrhosis. And it's more common in those that have lymphoma or leukemia. Right? And again, the liquid tumors and lymphoma are where this was truly first described as a problem. Virologic factors, you're more likely to see reactivation in someone that has detectable virus. And so again, that's important. You're more likely to see it in someone who's E antigen positive. You're more likely to see it in someone who doesn't have the hepatitis A, doesn't have the genotype A for hepatitis B. And I'll come to at the end, you're more likely to see hepatitis B reactivation in someone who was successfully treated with current DAAs for hepatitis C. So that's a whole nother area of hepatitis B reactivation, the patient who's cured of their hepatitis C. We define or divide risk of reactivation into 3 different groups: high risk, which would be a greater than 10% of reactivation, moderate between 1 and 10, and low risk, which would be less than 1%. Right? And that's very important. Why? You've seen a similar slide earlier presented by Dr. Locke, but the body has a very complex way of controlling the immune response elicited by the hepatitis B virus. If we were to interfere with that, then we allow potentially the hepatitis B virus to proliferate, reactivate, and cause its problems. And so the life cycle becomes important, but equally important is understanding where along the way we are interfering with the immune response and which ones are more important than others, so to speak, to go forward. When we think about immunomodulatory therapies, there are a whole host of them. I'll come back to, but would like to mention now perhaps the most critical to know about is rituximab, which has an extraordinarily high risk of reactivation. To the gastroenterologists in the audience, of which I think there are many, anti-TNFs place patients at risk for reactivation. So if you're practicing gastroenterology in an area where there's a high prevalence of hepatitis B, you really should look. And then there are other medications that we use. Rituximab is a particular problem and perhaps the best described. It's a monoclonal antibody against the CD20, which reduces the number of B cells and suppresses the immune response. It's commonly used now in non-Hodgkin's lymphoma, in CLL, but also in rheumatoid arthritis. So our rheumatology colleagues need to be aware of this. There is a significantly increased risk of reactivation with rituximab in those patients that are isolated hepatitis B core antibody alone. And that led to the FDA in the US issuing a black box warning regarding the importance of following these patients and looking for hepatitis B, and reminding us that reactivation can occur up to a year after the last dose of the medication. Right? Dr. Raj Reddy, who's another person who trained me at the University of Miami, published this paper back in 2015, which really looked at what groups are high risk, moderate risk, and low risk. So if we look to what would be your left and look at those patients that are surface antigen positive and core antibody positive, or surface antigen negative and core antibody positive, so isolated core, those patients getting B-cell depleting agents, of which rituximab is the most common, need to be started and then need to be continued for a year afterwards. In those patients that are surface antigen positive and core antibody positive, or just surface antigen positive, who are getting an erythrocycline derivative or who are getting higher doses of prednisone, at least 10 milligrams for more than 4 weeks, need to be started and need to be continued for 6 months after cessation of immunotherapy. Moderate risk groups are TNF, patients getting TNF inhibitors, patients who are getting tyrosine kinase inhibitors, or cytokine or integrin inhibitors. And these patients also, from this paper, are recommended, if they're core antibody positive alone, to be placed on therapy and to have that continued for at least 6 months after cessation. Other moderate groups would be those who are surface antigen positive, who are getting lower dose of prednisone, but for more than 4 weeks. And for those that are isolated core antibody positive, who are getting prednisone more than 10 milligrams for greater than 4 weeks, who are getting an anthracycline derivative, and these patients also should be treated for 6 months after cessation of the immunosuppressive therapy. Low-risk groups, those getting azathioprine, those getting 6-MP, those getting intra-articular steroids, those who are surface antigen negative but isolated core antibody positive, getting low doses of prednisone, do not need any type of antiviral prophylaxis, can then be followed. And so I would refer you to this paper because it really puts it out there very nicely and it's very easy to read. So how can then we prevent hepatitis B reactivation? Well, we need to look for it. And we need to check for surface antigen and core antibody as our first-line tests in all individuals undergoing immunosuppression. In those patients that are surface antigen positive, you should be checking for HBV DNA. You really don't need to look for hepatitis B surface antibody because it doesn't change what you're going to do for your patient that may not necessarily be protective as one goes forward. This looks at lamivudine and looking at two different approaches. Preemptive, meaning let's start the patient before they get immunosuppression, versus let's give it on demand once they've shown that they're developing a reactivation. And you can see here survival is better if you start earlier, before the patient is given immunosuppressive therapy, than waiting for a problem to occur. And I think most people would agree that it's better to start before the patient begins chemotherapy. This looks at tenofovir in patients that were starting rituximab, and you can see the group that got tenofovir versus the group that was just observed. Yes, the numbers are small, but there were no reactivations and no recurrent and no fatalities in the patients that received tenofovir. 16% of the folks who were just observed developed a reactivation. Again, a strong strong study to tell us that we should start therapy sooner before we start treatment. What are your options? It's really whatever is available to you, and you've heard about this. Whatever is cheapest will work. Entecavir, TDF, or TAF are all reasonable to use, and again, it's going to be dependent on what you can get. Ideally, this should be started before you initiate chemotherapy or immunosuppression, 1 to 2 weeks. But if you can start it at the same time, that's also good. You shouldn't hold chemotherapy or immunosuppressive therapy in someone who needs it while you're waiting for this, as long as you're assured that the patient can actually get it. And when you stop when you stop the hepatitis B studies, hepatitis B medications, you should also then monitor for hepatitis B reactivation after stopping. The AASLD recently changed and updated its guidance and recommends that all patients who are receiving immunosuppression, cytotoxic therapy, or any type of immunomodulatory therapy be screened for the risk for hepatitis B, surface antigen, and core antibody. And this goes along with the recommendations of the CDC in the US, EASL, and ASCO to look. And this has been a monumental shift from Dr. Locke's first description in 1991 to today. It took 20 to 25 years, and hopefully this will catch on. Still in the United States, the majority of oncologists don't look for hepatitis B before starting. And studies are showing anywhere between 30 and 40% now look. Going to conclude with just a few slides on hepatitis B reactivation after successful hepatitis C treatment, because I think this is a growing area. There have been now several descriptions of patients that had hepatitis C co-infected with hepatitis B, whose hepatitis C was treated. We now learned earlier this morning that we're curing everybody. And there have then been reactivation of the hepatitis B when the hepatitis C no longer is holding it at bay. This led the FDA in the US to issue a black box warning for all DAA therapies for hepatitis C that you screen for hepatitis B prior to starting. There were 29 cases that were reported. 2 were fatalities. 1 required a liver transplant, and 1 of the 2 actually was core antibody positive alone. And so this is something that you could look for. We haven't seen it in our practice, but again, our practice I don't think is large enough that you would actually find, because the numbers are small and the mechanism for reactivation is unknown. These are the recommendations from the AASLD to screen again for surface antigen and core antibody before initiating hepatitis C therapy. Obviously, if the patient fits the criteria for hepatitis B therapy, they should be started on that. If not, they should be observed. Right? And you may want to check every 3 to 6 months and every 3 to 6 months afterwards for a period of 6 months. So this is available on the AASLD website. So in summary, all patients who are to be started on immunosuppressive therapy, chemotherapy, or DAA therapy for hepatitis C should be screened for hepatitis B. The initial screening tests are a surface antigen and a core antibody. Prophylactic therapy is indicated for those patients that are high risk with either tenofovir or entecavir. And I'll stress again that hepatitis B reactivation is a preventable complication if we look and if we educate our colleagues who are going to be using these immunosuppressive therapies that exists. Thank you very much.